abnormalities, blood test abnormalities, and there's quite a few, and actually I've limited what I'm going to talk about in the presentation. As we go along, if anybody wants to comment or ask a question, that's most welcome. So before I start talking about the blood test abnormalities and what they can be and what to do about them, I thought I should present to you the joint lymphadenopathy clinic, whereby patients with lymph nodes pertaining or to the neck, basically any neck swelling which feel like lymph nodes. Nowadays at Warwick Hospital, we're quite lucky. We get them through the joint lymphadenopathy clinic, and you can refer directly to Sully, Mr. El-Shunnar, the ENT consultant, or to me, and just say the ENT Haematology Lymphadenopathy Clinic. It's really well run. So what happens is that patients with lymph nodes, particularly of the neck, get seen jointly between myself and Sully, and then we'll decide whether they need a biopsy. A lot of times not, and whether the biopsy should be a needle true cut biopsy, which is done by Ramesh. He's our Superman. He's able to do lots of biopsies, which in the past were thought not to be feasible. It's really good, but there are occasions whereby an excision biopsy is really needed instead of a true cut. So it's quite a useful clinic to be aware of. So I'll start with thrombophilia, and I think I ought to say, so the slides I'm using were done by a group of hematologists quite a number of years ago now, and I've just updated it a bit. And they were done in common between Warwick consultants, a consultant from Nottingham, and so on. So you'll find these now prevalent throughout a lot of hospitals in the country. So let's start with thrombophilia. So thrombophilia testing is to try to determine if there are blood factors which increase the risk of the patient for thrombosis. Thrombosis can be in the venous system and in the arterial system, and generally only the lupus anticoagulant is commonly used as a thrombophilic factor for arterial thrombosis, because the other factors just increase venous thromboembolism, but not arterial thrombosis. So if there is an arterial thrombosis, then you need to consider referring to the appropriate specialist, stroke physician or cardiologist or vascular surgeon. Very rarely is there is a hematologist involved in arterial thrombosis. Now, there are really only a few indications for a thrombophilia screen, and a lot of my colleagues think that there's almost never a need to do a thrombophilia test, and I'll explain in the slides after this one. There are a few reasons. One, because thrombophilia testing is never exhaustive. So a negative test does not rule out an inherited tendency to thrombosis. We think that more than 50% of patients have a family tendency, if not a direct inheritance, but the factors have not yet been discovered scientifically. Also, most people who carry the more common prothrombotic abnormalities and they can be very common, particularly in European populations, such as the factor V Leiden. It's found like in almost 10%, 8% of the population, depending which country you're in. But let's say the factor V Leiden will never have, a patient with a factor V Leiden will almost never have a thrombosis. So if you screen and you get a positive result, that's not going to influence management and what you're going to advise the patient and the duration of anticoagulation, of prophylactic anticoagulation. So for that reason, screening of family members who've never had a thrombosis is not advised. Patients who have had a thrombosis, which is clearly provoked, will have a time-limited period of anticoagulation, and that will terminate regardless of whether the patient is going to be positive for factor V Leiden. I'm mentioning factor V Leiden because it's by far the more common thrombophilic factor. Patient with a spontaneous patient with a spontaneous thrombosis are often offered ongoing anticoagulation, again, regardless of the thrombophilia screen result. So nowadays, a spontaneous thrombosis in a proximal vessel, a venous vessel, we tend to give them 12 months, which seems to be a cutoff between the balance of risk, benefit, and risks. So to say, the risk of bleeding from continuing anticoagulation will start exceeding the benefit of reducing the recurrence of thrombosis. And fifthly, a family history of venous thrombosis in a first-degree relative is straight away a relative contraindication to the use of estrogen-containing contraceptives, including of HRT, and that's irrespective of whether there is defined thrombophilia or not. And then the laboratories still offer genetic testing for various clotting genes, which have very weak clinical significance, and these tests are not recommended. So that's a slide of why not to do. And so thrombophilia screen, when to do. So almost never, that is. And that's because a detailed clinical history taken in conjunction with simple clinical tests with the D-dimer in particular. So if you get a D-dimer over a level of 2 in particular, that means usually there's ongoing subclinical fibrinogen, which usually, but not always, indicates some kind of ongoing subclinical thrombosis. And also a very high D-dimer level at presentation is predictive of recurrence of thrombosis, but mostly it's the clinical analysis, clinical risk features, and will identify those whose risk of recurrence is high enough to warrant long-term anticoagulation, and on the opposite side, which is not lowered significantly by the absence of a thrombophilic trait. These clinical factors will also identify patients with low risk of venous thromboembolic disease and not requiring long-term anticoagulation, even in the presence of weak thrombophilic factors such as the factor V Leiden and the prothrombin G mutation. Selective testing of asymptomatic first-degree relatives, of proband, of patients with protein C, protein S, and antithrombin deficiency may be considered when this can influence the management and life choices depending upon personal circumstances, but I have to say these are quite rare. When to do? Well, I'm saying that there's no evidence that the presence of heritable thrombophilia influences the intensity, the choice, or the monitoring of anticoagulation, anticoagulant therapy when treating thrombosis, except potentially for those with antithrombin deficiency. And here you have to be sort of specific. It's not just any antithrombin deficiency. It's mostly the homozygous state, whereby diagnosis is usually heralded by a very early onset, I mean, during young age, of extensive thrombosis. And in that case, it's valuable to know because you can give antithrombin concentrate as treatment. And also you'll be able to interpret the dosing of heparin for anticoagulation better, knowing a person is antithrombin deficiency. But this is an extraordinary rare disorder. So when to screen, you ought to screen at least after 3 months of anticoagulation, and certainly once the anticoagulant has been totally metabolized from the circulation. So you need to know the half-life of, like warfarin, we say at least a week, with the DOACs a week as well, but really a few days, 3-4 days is enough usually. So the last couple of years, Genomics England has come up with the so-called R97 panel, and it comprises all the currently 15 genes known to be associated with pro-thrombosis, but certainly that will increase, and some will be taken off and some will be added in the future as more knowledge is gained. And its role is very limited. I mean, before I came to the talk, I was having the hematology meeting across the county, and none of us have ever used it, but it's there to use, and it's limited to those patients less than 40 years of age with a strong personal or family history of spontaneous venous thromboembolism without any of the identifiable genetic thrombophilia. And testing should only be used where therapeutic management will be influenced. So I've just realized that I didn't outline what the thrombophilic tests are. I'm sure you all know them, don't you? So there are the inherited mutations, that's the factor V Leiden, the prothrombin gene mutation, and there used to be the MTHFR mutation, but it's been realized it's a weak mutation, so we're no longer testing for it in most laboratories at least. And then there are the functional tests, and that's for antithrombin, used to be called antithrombin 3, protein C and protein S. And as I mentioned, the lupus anticoagulant is another functional test, but that's not inherited, that's acquired. So here we come, thrombophilia screen for acquired factors. And here it's good to mention that the acquired factors can lead to both arterial and venous thrombosis. So when do you check for paroxysmal nocturnal hemoglobinuria? This is a flow cytometry test, but it could be a mutation test as well. But the most one easily available and with the most rapid turnaround is the flow cytometric analysis for PNH. So you test when there is a thrombosis in unusual sites with some abnormal hematological parameters, such as 1 or 2 low blood counts or abnormal indices, like very often you get a low MCV and a bit of anemia, because PNH can lead to intravascular hemolysis, hence the anemia, and iron deficiency leading to the low MCV. Or there is evidence of hemolysis, so anemia with hemolysis, like if you find a high LDH or reticulocyte count or depressed haptoglobin, that should trigger thinking about this test. And then the myeloproliferative neoplasm panel, that's a mutation analysis for the JAK2 exon 12 and the calreticulin and the myeloproliferative ligand mutation. You check for these if you see thrombosis, again, at unusual sites with a hyperproliferative pattern to the full blood count, so a high red cell count or a high platelets, or usually. You also check specifically for the JAK2 mutation. Nothing else has been associated in patients with thrombosis in the portal venous system, and including the mesenteric veins. And also, if you've got one of the cerebral sinus thrombosis, when there's no clear provoking factor. So usually there's a provoking factor like a sinus infection traveling upwards to the brain, injury, and so on. Going on to thrombophilia screen for arterial thrombosis, excluding stroke. So thrombophilia screen, that is for heart attacks and other cardiac thrombosis and peripheral vascular thrombosis. Heritable thrombophilia testing is not recommended because they just don't give rise to arterial thrombosis. And so what's recommended is checking for the lupus anticoagulant and antiphospholipid antibodies in the absence of vascular the much more common vascular risk factors. And again, in patients with arterial thrombosis and the relevant full blood count abnormalities, you would want to consider a myeloproliferative neoplasm mutation screen and the flow cytometry test for PNH. So specifically thrombophilia screening for patients with stroke. Same thing goes, heritable thrombophilia, it's for venous, so you don't check it in strokes. And you would really want to check it every time in a patient with a stroke below the age of 50 years, because remember, the antiphospholipid syndrome is an autoimmune disorder, which typically it's more common in young and middle-age patients. And again, you only check for it if you cannot identify any risk factors for cardiovascular disease. And same thing goes, I'm repeating myself, abnormal full blood count in a stroke patient, think about doing the JAK2 and the other panels and think about PNH. We get asked, particularly in hospital, to do a thrombophilia testing for patients who have a stroke with a patent foramen ovale. There's no indication for that. There's no association. What about thrombophilia screening in pregnancy morbidity, which used to be in vogue a few years ago? With increasing knowledge and publications, it's really decreased a lot. So heritable thrombophilia screening in women with pregnancy complications such as... Hello? Shall I continue? Heritable thrombophilia screening in women with pregnancy complications such as recurrent miscarriage or other adverse pregnancy outcomes is not recommended. There's been now several very large meta-analyses which have failed to demonstrate the benefit of low molecular weight heparin and/or aspirin to improve pregnancy outcomes. There are some exceptions. So for women with recurrent or late, that's after 20 weeks pregnancy and loss of the pregnancy, screening for antiphospholipid antibodies should be considered, as the results will aid in the risk stratification and the treatment decisions. And that's in particular if you get the triple hit, a triple positive antibodies. So that would be the anticardiolipin, IgG, and IgM, and much more importantly, much more significant is the autoantibody for the beta-2 glycoprotein 1. And you find all three together, that's really quite a high risk of thrombosis in the setting of late pregnancy loss. And in this treatment, really, there's been some studies which showed a combination of aspirin and low molecular weight heparin in patients with previous thrombosis will improve pregnancy outcomes and delivery. The thing to be aware of is that antiphospholipid antibody can be transiently positive, so during pregnancy, so there could be false positive, but usually not the beta-2 glycoprotein 1. That's why we try to look for triple screening and only treat if there's triple positivity, or if after pregnancy the lupus anticoagulant and or the antiphospholipid antibodies remain positive. And that would be at least 3 months after pregnancy. What about, it's quite a common question we get, venous thromboembolism and traveling. So it's interesting to know that in normal people, healthy people, one will get a venous thrombosis or a pulmonary embolism in every 110,000 flights on average, lasting less than 4 hours. And one event, one person will get a thrombosis venous in every 4,500 flights. So that's a good sort of indicator of how frequent it can be. Again, when you want to advise patients, you need to go through the risk factors. And I'm sure you're very much aware of all of these. So what are the risk factors for venous thromboembolic disease? It's previous thrombosis when they were not on anticoagulants, active cancer, recent surgery that's really within the first 6 weeks and about 8 weeks really, particularly if the surgery was in the legs, pelvis or abdomen. A family history in a first degree relative, over 60 years of age, inherited thrombophilia, significant varicosities of the legs, and the large cord-like varicosities, that's a risk factor. And clearly, if there's evidence of chronic venous insufficiency in the legs, limited mobility for whatever reason, usually fractures, isn't it? A body mass index of more than 30, polycythemic levels, particularly if it's polycythemia vera due to myeloproliferative neoplasms. So polycythemia vera, that's the cancer. I would start worrying if the hematocrit is more than 45. With secondary, I wouldn't worry much unless it's like clearly above a hematocrit of 0.55 and probably 0.6 really. Pregnancy is a thrombophilic state and up to 6-8 weeks postpartum. And then there are the sort of vasculitic disorders, the chronic inflammatory disorders, hemolytic states, which are all prothrombotic, and clearly the estrogen pills. So what would you advise a patient who comes to your clinic about traveling? Well, you might reassure them immediately that they don't have any risk factors, or the factors are so weak that can be ignored. It needs to be a two-way discussion, and ultimately they have to take the decision. And in patients with a personal history of venous thromboembolism, you may agree after discussion to offer them either enoxaparin, low molecular weight heparin, or rivaroxaban in all flights over 4 hours. And if they had a thrombotic event, which was associated with a flight of less than 4 hours, then you offer it to all these patients in this category. Rivaroxaban is far more convenient to use than enoxaparin. You give 10 milligrams dose prior to flying each way for every 24 hours flight. So like if you want to go to New Zealand, you're probably going to take 10 milligrams daily for 2 days or so, depending upon how many stops there are. For patients who have weak risk factors, clinical risk factors as indicated above, class 1 stockings should be enough. So just to give you a pointer, we use class 2 grade 2 stockings for post-thrombosis syndrome, class 1 really for the situation. Or it could be simple flight stocks. And you need, I'm sure you remember that if the APBI is less than 0.8, you might not want to put any further pressure to constrict the arterial circulation. Aspirin is no good in the situation. And then, although clearly not proven, we always advise the patients like to pump their feet every 5 minutes, 10 pumps every 5 minutes, or walking up and down the aisle every 30 minutes, this sort of thing, and to keep well hydrated. It's always prudent that they inform the travel insurance if they have pre-existing problems in case they get venous thromboembolism, which the insurance can link to their pre-existing problems. Okay, changing tact, coming to blood cell count abnormalities, neutropenia. So neutropenia, my experience in general is not serious, but a minority, it can be deadly, can be very serious. So a normal neutrophil count is between 2 and 7. Neutropenia, therefore, is less than 2, but in practice, we close our eyes. We don't count between 1.5 and 2. We start saying that mild neutropenia starts below 1.5 up to 1. Moderate is less than 1 up to 0.5, and severe is below 0.5, and very very severe is less than 0.2. And as you can imagine, the risks of serious and opportunistic infection start below 1, but really get high below 0.5, and especially when the neutrophil count is less than 0.2. So you've got this patient in your clinic, in your surgery. You go and ask about recurrent infections and mouth ulcers, which would indicate the clinical severity and importance of the neutropenia. You ask about a family history and those who are below 30 years of age, because it could still be a congenital kind of neutropenia. And you always ask and examine for autoimmune disorders and liver disease, which could be autoimmune but can be associated with hypersplenism, a cause of low neutrophil count. And you always examine for lymphadenopathy and splenomegaly. Should have started saying that first. It's very important when you start categorizing your approach to a neutropenic patient to establish whether it's a chronic neutropenia for more than 6 months, 6 months really, or an acute one less than 3 months, because with an acute neutropenia, it tends to be quite transient, usually associated with infection or some medications. Tests, you always do a viral screen, HIV and the hepatitis. You do the liver and thyroid function test looking for autoimmune. You always check the B12 and folate. not uncommon a cause of isolated cytopenia, a low neutrophil count or platelets. It can cause it in isolation. So management really of neutropenia will vary upon the clinical significance. So if a patient has neutropenia but is really well, it's not as important as somebody who is presenting with infections or mouth ulcers and so on. You consider stopping any medications which are associated as a side effect of neutropenia, and not uncommonly, particularly in the younger patients, you see viral infections causing isolated neutropenia, initially presenting on the blood film with atypical lymphocytes. And that can last for really for up to 6 months. I've seen patients even longer than that, and then it settles. Neutrophil count, which is mild, between 1 and 1.5. You rule out the autoimmune disorders, the viral infections, and you repeat in 4 weeks' time, and if stable and the patient is really well, you stop investigating. A neutrophil count, sorry, that's 1.5 and above. A neutrophil count of less than 1.5 to 1, you do the same thing, but do a bit more frequent monitoring, and still low, just discuss the case with a hematologist through advice and guidance usually. And if there's no associated full blood count abnormalities, or the counts are normal other than for an isolated neutropenia, or there are no clinical concerns, you can still monitor them in primary care. A neutrophil count below 1, that's when the lab does a blood film, and the results can guide the frequency of testing and the timing. So in general, if someone with a neutrophil count persisting below 1 after 2 weeks, that requires referral to a hematologist. If the neutropenia is associated with other blood count abnormalities or morphological abnormalities, or there are recurrent infections, then that's when you want to make a formal referral. Remember ethnic neutropenia of Africans and Middle Eastern ethnicity, whereby it's quite common to have a neutrophil count below 2, down to 0.8. Less than 0.7, like you start to worry a bit that it's not a genetic and totally benign neutropenia. But you have to remember this is a diagnosis of exclusion, so you would want to investigate as above. If a patient has a neutrophil count of less than 1 and is presenting with fever or any signs of sepsis, that's neutropenic sepsis. Keep in mind that in around 20% of neutropenic sepsis, the patient is really poorly, but he's so frail, the patient is so frail that they don't mount a fever. It can be normal or sometimes hypothermic. So if a patient has a neutrophil count of less than 1 with or without a fever, but there's otherwise signs of infection, that's an emergency. He needs to be hospitalized for intravenous antibiotics. A low lymphocyte count, so really that's below 1. A whole host of causes, so could be acute. I mean, acute lymphopenia is very much like doing an ESR. Chronic lymphopenia, that indicate there's something wrong going on, and it could be because of serious comorbidities, heart failure, renal failure, very severe diabetes with complications. Long-term steroids can do that, but there are the serious diseases like you can get tuberculosis and HIV infections, autoimmune disorders, and then you can get the cancers like the lymphomas. Non-Hodgkin and Hodgkin's can give rise to lymphopenia, and the congenital immunodeficiency syndromes, at least one of them. So when you take a history and examination, you have to consider these causes. I mean, lots of tests should be done, but I've highlighted the HIV test, as we do get some patients undiagnosed presenting to hematology. So management, if the lymphopenia is persistent with no secondary cause and no clinical concerns, then no further action is required. It is extremely unusual for a patient to have a lymphoma with the sole presenting feature being lymphopenia. However, if there are clinical concerns, enlarged lymph nodes, increased lymph nodes, B symptoms, then clearly refer. If the patient has recurrent infections and is lymphopenic and HIV negative, then always check the immunoglobulins, and if the results are abnormal, you may think abnormally low, you may want to refer to an immunologist. Going to a high lymphocyte count, so really that's a lymphocyte count of more than 4. Actually, in our lab, it's more than 3.2, but that generally taken more than 4. It depends upon the range established for each particular full blood count machine. So remember, in children below the age of 2, particularly below the age of 1, the lymphocyte count may be high, particularly below the age of 1. And in younger patients, in young adults and younger, the lymphocytosis is in almost 99% reactive, whereas in the elderly, above the age of 55, really, not just the elderly, it tends to be more a cancer, a clonal disorder, a sort of a non-Hodgkin lymphoma, leukemic phase, usually chronic lymphocytic leukemia. But you have to go through the differential, so go to the chronic viral infections, bacterial, particularly again tuberculosis. Pertussis is really more acute. Hyposplenism, remember hyposplenism or splenectomy, post-splenectomy, that is, can give rise to high numbers. Smoking is a really common cause of lymphocytosis, and it could be an acute stress response. And then it could be what we were saying, like a lymphoma, non-Hodgkin's lymphoma in leukemic phase, of which chronic lymphocytic leukemia is the most common. History and examination, therefore, relies on looking for the B symptoms, looking for possible causes, and investigations. Again, you need to think about the causes. So what about management? If you don't think there's anything along the lines of a cancer, blood cell cancer, you repeat the full blood count in 4 to 6 weeks, and very often you get a resolution. Sometimes clinically you're quite sure it's reactive, so you wait 8 to 10 weeks, 12 weeks, and it settles eventually. If there are recurrent infections, B symptoms, hepatosplenomegaly, other abnormalities of the full blood count, then refer to hematology. If there are concerning features on the blood film, again, refer to hematology. And in older patients, a persistent lymphocytosis is more than likely a hematological cancer, the most common chronic lymphocytic leukemia. there is really no advantage of early treatment in these patients with incurable cancer unless they are symptomatic. And therefore, depending upon their age, comorbidities, there is really no rush to establish a diagnosis, particularly when it's a mild persistent lymphocytosis in an otherwise well patient. And you know, as I've sort of got older, I've seen time and time again that you make a diagnosis and you may think that you're really clever in making a diagnosis. At least I used to, but it's not going to influence life expectancy in a asymptomatic patient who is like older than 75 years of age, and it will have a huge impact on his traveling insurance and medical insurance and so on. So you might want to think twice actually on whether you want to make a diagnosis or not. So continuing on lymphocytosis, a lymphocyte count persistently above 10. Have a discussion on advice and guidance to determine the best management strategy. Lymphocyte count persistently about 20, then I think that really merits a formal referral to a hematology outpatient clinic. If your patient is found to have CLL, chronic lymphocytic leukemia, based upon the blood count and flow cytometric immunophenotyping, then you don't necessarily require referral to hematology unless the patient really wants to have a discussion. So in general, therefore, patients can be monitored in primary care if they're well, they have no B symptoms, there's no or minor lymphadenopathy, and the full blood count is otherwise normal, and the lymphocyte count is stable, certainly if below 30. So a diagnosis we would usually monitor every 3 months for the first 12 months, 6 monthly for the first 2 years, and come the 4th year annually thereafter. And then you would want to refer back to hematology if there's the development of cytopenia. Clearly, if anemia, you want to exclude the much more common iron deficiency anemia. Or if there's progressive organomegaly, which is particularly splenomegaly and lymphadenopathy, or if the lymphocyte doubling time is less than 12 months, but because that has been recognized to be a poor prognostic feature, and the patient is likely to require starting chemotherapy or immunochemotherapy or biological therapy, which is now becoming the standard within 24 months. Going forwards, anemia. So really, I said normocytic here because macrocytic anemia and microcytic anemia are quite rare unless the macrocytosis is due to iron deficiency. And anyway, normocytic anemia investigations and the differential encompasses all the diagnoses or the differential between microcytosis and macrocytosis, macrocytic anemia, I should say. So in males, normal ranges are 130 to 180. In females, 120 to 165. And we always try to separate anemia according to the MCV, and I should say also according to the reticulocyte count. However, MCV is really not that sensitive or specific. So even if there's no MCV, you need to investigate for causes of a macrocytic anemia. By far, the most common leading cause of anemia is bleeding and occult bleeding, giving rise to iron deficiency, occasionally iron deficiency not due to bleeding. Anemia of chronic disease is extraordinarily common, particularly in the hospital setting. And then there are the cancers. Always remember myeloma. if you've got a chronic kidney disease or acute kidney injury, you can quickly get anemia, particularly if the GFR is less than 15, but really even less than 30. And diabetes, particularly if it's associated with microvascular complications, chronic liver disease and alcoholic liver disease, and malnutrition and with an alcoholic state. The hematinic deficiencies, B12 and folate deficiency, hemolysis, often drug-induced, occasionally drugs cause aplastic anemia. And clearly chemotherapy can cause this, but also like the anti-androgens and immunomodulators that are increasingly used in for ulcerative colitis and rheumatoid disorders and psoriasis and so on now. And pregnancy can cause a dilutional effect, which we tend to ignore unless it's like symptomatic and below 80. Testosterone deficiency is really common, I find, in elderly men. Thyroid dysfunction, particularly hypothyroidism, thalassemia and hemoglobinopathies, that can be extremely common depending which area you're looking after. And then you've got the bone marrow failure syndromes, the bone marrow cancers, really, or aplastic anemia. So anemia, really, it's an interesting challenge because it could be anything, and you just need to take a really good history and examination to try to establish a clue. And again, you need to establish whether it's chronic or acute. So you need to check for all these investigations, but I would think iron deficiency and anemia of chronic disease and chronic kidney disease are really by far the most common, but you always check for myeloma by doing a serum protein electrophoresis and immunoglobulin levels. And treatment very much depends upon the cause, and if all the secondary causes are excluded, you're going to end up with either anemia of chronic disease or one of the more serious bone marrow failure syndromes. And bone marrow failure syndromes can be just isolated to the red cells, but you get a really good clue if there are other cytopenias, low platelets or low neutrophils and so on, or if the blood film shows morphological abnormalities. So in patients with anemia, chronic anemia, with an otherwise normal full blood count, and for those whom there are no concerning features, we suggest monitoring the full blood count in general practice, and that could be simply every 6 months. In anemia of chronic disease, sometimes that requires treatment, but clearly the treatment is the treatment of the underlying cause, and you might want to refer therefore to the appropriate specialty depending upon the cause of the anemia of chronic disease. Saying that, in a few exceptional patients, we use erythropoietin therapy, which is not funded, but can really alleviate the patient's symptoms. A large red cell size, macrocytosis. So we take it generally as more than 105, but again, it really depends upon the full blood count machine servicing the local laboratory, because it could be like more than 101, more than 100. I think artifact, and because there's a delay in analysis of the blood sample, is a quite common cause. You repeat it and comes back to normal, and then you go through the usual, which I'm sure you all know: liver disease, alcohol, B12 folate deficiency, hemolysis, because remember, the young red blood cells, the reticulocytes, are much larger than the more mature red cell. Lots of medications, methotrexate given for rheumatoid or psoriasis and so on. Chemotherapy can do that. If you have a high enough level of a paraprotein, pregnancy, endocrine states, particularly hypothyroidism. And then you always remember the bone marrow cancers, such as myelodysplastic syndrome or aplastic anemia, which can be immune very often. History and examination and suggested investigations, that's very much depends upon investigating for the causes. I would say consider referral for a macrocytic anemia if the hemoglobin is persistently below 110 in males or less than 100 in females, and there are no obvious secondary causes. If the NCV is high, but there's no anemia, which is not uncommon findings, then this could be monitored in primary care every 6 months, but eventually every year until such time that a cytopenia develops. Macrocytosis, well, iron deficiency is by far the most common. Hemoglobinopathies in the right ethnic setting. Anemia of chronic disease. I mean, once every 10 years or so, we diagnose lead poisoning. And then there's an inherited sideroblastic anemia, which I've never seen more than 20 years I've been at Warwick. So iron deficiency, you should get a low ferritin. If you get a normal ferritin, you need to make sure that the inflammatory markers, the CRP and the ESR, are not raised, because ferritin is an acute phase reactant, and you can get a false normal ferritin. With lead poisoning, you really need to think about doing a blood film. You get the typical stippling of the red cell cytoplasm. You check the red cell folate, and you check for the zinc protoporphyrin level, which unfortunately we've stopped doing in the lab, but we can refer it. I mean, there's been a shift now in hematology. We really stopped looking after investigating patients with iron deficiency or treating them. It's gone almost totally to the GI team. And in the last 9 months, the medical day case unit has been accepting direct referrals from primary care for parenteral iron infusion if you think that's needed. So you don't need to come to us really, unless you want to have a discussion, of course, but that could be just as well by the GI team. Hematology has really stopped looking after iron deficient patients. Polycythemia, that's defined in males, hemoglobin over 180, in females 165. Really, the trick is to tease out whether the polycythemia is due to a bone marrow cancer. That's the primary polycythemia, still called polycythemia rubra vera. And if you find no causes of secondary polycythemia, such as cyanotic congenital heart disease, but much more common, COPDs, occasionally when you investigate for secondary polycythemia, you find polycystic disease of the kidneys, or renal transplant patients. They commonly can present with polycythemia. But if you find no secondary causes, you do the JAK2. Unfortunately, the lab has stopped the general practitioners to do the JAK2. I'm not really sure why, but that's how it is. So, but if you correspond with us through advice and guidance, we could do the JAK2 mutation for you. And if the JAK2 mutation is positive, and that would prove that there is a myeloproliferative neoplasm. Sorry, I'm jumping because I've taken too long. If the hematocrit, I'm jumping to management now. If the hematocrit or hemoglobin is only mildly elevated, so let's say we go by hematocrit really. If the hematocrit is less than 0.55, it's reasonable to offer lifestyle advice and repeat the test in 3 months. If any secondary causes are apparent, they should be treated specifically, such as smoking cessation, stopping diuretics, optimizing bronchodilator therapy, stopping alcohol, excess alcohol, and so on. If there is an elevation in hematocrit associated with a thrombotic event or hyperviscosity syndromes, then that should be an urgent referral. Ideally pick up the phone and talk to one of us in hematology. If the patient is hypoxic due to a cardiac or lung disease, then refer to the appropriate specialty. If there is clinical suspicion of the cancer, polycythemia rubra vera, in that there are constitutional symptoms, a large spleen, and no secondary cause can be found, again, refer to hematology. If secondary polycythemia seems likely, but primary polycythemia needs to be excluded, I mean, again, I'm repeating myself, get advice and guidance, so that will help you do a JAK2, will do it for you. I hope that is turned over and you can request JAK2 yourselves. So please refer to hematology if the hematocrit is persistently high. So you do a full blood count 3 months apart, persistently higher than 0.52 in a male and 0.48 in a woman, and no secondary cause is found. If the hematocrit does not reach these thresholds, but the MCV is low or the ferritin is low, then that often can be the cancer polycythemia vera becoming iron deficiency, and then you need to refer. If the hemoglobin is more than 0.6 in a male, more than 0.56 in a female, or if there's any high hematocrit level with hyperviscosity syndromes, then that requires an urgent referral. Thrombocytopenia, the lower limit of a normal count is 150, but we generally start worrying below 50, particularly below 30. Probably the most common cause of a low platelet count is EDTA-caused EDTA related clumping of platelets. So what you do simply is you retest the platelet count, the full blood count, in a citrated bottle rather than the standard EDTA-coated bottle. But there's a whole host of differential which you could read when you can take this presentation for and you can sort of keep it in your library. I guess if the platelet count is below 50, particularly below 30, if there is easy bruising and large ecchymosis, which means bruising of more than 4 or 5 centimeters, if there's bleeding, then refer to a hematologist. Thrombocytosis, just to say that thrombocytosis is commonly due to an acute reactive state, but if it's chronic, lasting more than 6 months, then it's usually due to chronic iron deficiency, a chronic inflammatory disorder, or a bone marrow cancer like a myeloproliferative neoplasm. If you have clinical concerns, if the patient has a history of thrombosis, is age over 60, has a large spleen, constitutional symptoms, and that's when you refer to a hematologist. Paraprotein. So I realize I've overrun. Shall I do this last slide or? Yeah. Okay. I'll just finish quickly. So paraprotein, remember, almost everyone will have a paraprotein above the age of 75, particularly above the age of 80. For paraprotein, you look for significance. So on a lab point of view, you want to see whether the paraprotein is really high. So it's usually less than 30, but most often less than 15. If it's beyond that, you start suspecting a cancer. such as a multiple myeloma or a lymphoma, a B-cell lymphoma. If the serum fluoride ratio is very abnormal, as indicated in the last two lines here, then you would want to refer to hematology. But really, in most cases, so I think you can see this sort of calculator here. If I bring it up, I'm not sure, can you still see it or not? I'm not sure whether you can still see it. Or have I gone out, lost you?
No, yeah, you're still with us, Dr. Borg.
Okay, so like if like I think this is very usual for you at your surgery. So you find a paraprotein, you want to quantitate the risk, and let's say it's less than 15. Yeah, and what's the protein? Let's say it's the more common IgG. What's the serum fluoride ratio? Let's say it's normal. Then you click view the results, and you can see that the absolute risk of progression of transformation to a cancer of the lymphocytes, multiple myeloma or lymphoma or leukemia, is 5% over a period of 20 years. So that's no risk at all, is it? So you might want to think of not monitoring the patient, particularly if they're like over 80 years of age, because nothing is bound to happen. But then there are the high risk, and then you really need to keep an eye on them. And I'll stop here, conscious that I don't want to continue talking, and I can do that very easily. So, okay, thank you for having the patience of listening to all this.
Thank you, Dr. Borg. Just before we go, is there does anyone have any questions? I appreciate we've run over, but if anyone's got any questions, if they want to take themselves off mute. No, we've got some comments to say. Thanks for a very useful presentation. Thank you very much.
I think it would be good if you would want to take it for your library, and then might be handy.
Yeah, certainly. Well, the session has been recorded this evening, so as I said earlier, I will send the link out with CPD certificates for anyone who wants to revisit the session. And Dr. Borg's kindly said that the slides can be sent out as well. So I'll arrange for that over the next couple of days. Thank you, Dr. Borg. I know it's a very popular topic. We had lots of people registered for the event and lots of talk about the event. So thank you very much for joining us this evening, and thank you everyone else for attending and listening in this evening. Like I say, I know we've slightly overrun, but I hope you enjoy the rest of your evening. Okay. All right. Thank you, Dr. Borg. Thank you.
Bye.
Thank you.
Bye.
Bye-bye.